And for many of you may not know, that's the new nomenclature for NASH or fatty liver disease. We've taken away the terminology non-alcoholic and replaced it with metabolic. So be prepared to see more about that. That'll be a topic for another talk for a future symposia. So the other considerations: does this patient have gallbladder disease, hepatitis C, autoimmune hepatitis, or primary biliary cholangitis? And so hopefully by the end of this lecture, we'll circle back to this case and see what we think the cause is. Next slide. So I'll begin speaking about primary biliary cholangitis today. So many of you may have heard of the disease PBC, but back in about 10 years ago, we changed the nomenclature of the disease from primary biliary cirrhosis to primary biliary cholangitis. And this was done simply because not all patients who have this disease have cirrhosis. And that is very confusing for patients, that you would tell them you have mild disease, but then the word cirrhosis in the title, they go on the internet or look it up and all of a sudden think they need a liver transplant. So it was a good change for patients and providers to have a more accurate description of the disease. But as I already mentioned, this is a disease that 90 to 95% of the patients are female. And so this is squarely a disease that we see in our female patients and that we need to be aware of and thinking about that when we're doing their evaluations. So about 15% of patients will become decompensated over 5 years. And what that means is that their liver gets sicker and may need to be evaluated for a liver transplant. So the overall etiology of the disease is thought to be due to genetic and environmental triggers. The main problem is that you develop loss of humoral tolerance, an increase of specific T cells in the liver to the pyruvate dehydrogenase complex. So for those of you that may not remember, your pyruvate dehydrogenase is primarily in your mitochondria, your energy center of your cells, and hence this is the anti-mitochondrial antibody. But what triggers this, no one knows for sure, but what has been hypothesized are there are some environmental triggers, and some of these may be contained in cosmetic agents or metabolites from acetaminophen that may be part of the trigger for this. So if you start to think about that, that could explain potentially where we see some why we see some of the gender differences or sex differences in this disease, but certainly food for thought there. Next slide. So this disease is characterized by biochemical cholestasis, and primarily the lab abnormality you see is alkaline phosphatase elevation. There can be mild AST and ALT elevations, but usually that is normal when we see these patients. The main antibody test that's part of our assessment is the antimitochondrial antibody. This is found in the majority of patients with PBC, but interestingly, 0.5% of the population is positive for the AMA, but do not have PBC. But once you have detect a positive AMA, there's a 17% 5-year incidence of the disease. So it is a warning sign that you will want to watch these patients and follow their liver tests specifically. You can also see an elevated serum IgM level, and then other autoantibodies such as the anti-nuclear antibody and smooth muscle antibody can be present. And one of the things that has changed in our thought of this disease is that this is a diagnosis that can be made clinically, and that you do not have to have a liver biopsy, where when I started my training, we would biopsy the majority of these patients before initiating treatment. Next slide. So when we look at the liver biopsy under the microscope, these have some very characteristic features. So the thing people may remember from their medical training is the florid duct lesion, and this is where you get specific inflammation around the bile ducts. This can lead to the bile duct damage, and eventually you can get bile duct loss, which is called ductopenia. And so this is what causes the elevation in the liver tests and the symptoms of cholestasis that these patients have. Next slide. So the main symptoms in patients with PBC, the primary ones we see are listed here. Fatigue is the most common. These patients just feel very tired, very wiped out. They have no energy. It's difficult to get out of bed. It's difficult to do the things that they enjoy. And so they have an overwhelming fatigue, which is disabling for many patients. The other thing that we see very commonly in these patients is pruritus, and this has to do with the cholestasis. And some of these cases can be so severe that it is entirely disruptive to their life. You can imagine if you're scratching all the time, you're not going to get appropriate sleep. This is going to become a circular problem with your fatigue and low energy and really decrease the overall quality of life of patients. Occasionally, we may see some pain, but that's not a predominant feature. PBC is clustered with other autoimmune diseases that are seen. Sjogren's syndrome is seen in 45 to 60% of patients with PBC. So patients very frequently will have these symptoms. There's also an association with CREST syndrome that we see, scleroderma, Raynaud's disease. Potentially, we also see an association with thyroid disease, celiac disease. So many times we get referrals from the rheumatology clinic where patients will come in for a rheumatologic evaluation. The antimitochondrial antibody will be checked and it will be positive. And lo and behold, when you go back and see this patient has had elevated alkaline phosphatase for some time. And so I think increasing our awareness of this disease certainly will help with identification and diagnosis and treatment. So when we examine these patients, we frequently will see skin excoriations. In the worst cases, the patients just can't even sit still. They're scratching so much in the visit, and you immediately have an idea of what's going on. You can see xanthelasma, which are the cholesterol deposits around the orbit, and then xanthomas, which are seen in other parts of the body over extensor surfaces, and about 20 to 30% of patients may have hepatomegaly. Next slide, please. So there are two models that we use to identify the prognosis of these patients. And I put this up here just to show the things that we really track and look and pay attention to in following these patients over the years. So the main components of the blood work with the bilirubin, albumin, alkaline phosphatase, and platelet count are really the key factors that we look at. And there's two models that can be looked at online. You plug in the variables and then can help you see what the overall prognosis and direction your patient may be going and follow these patients. Next slide. So one of the key things we do for all liver diseases is to assess fibrosis. And so what that means is to assess how much scar tissue there is in the liver. And believe it or not, as a hepatologist, this is tantamount the number one thing that we look at. I'm much more interested most of the time of how much fibrosis a patient has rather than what their ALT is. And so I will focus more on this aspect and then look at liver tests in assessing the patient because this really associates most with the patient's prognosis. So fibrosis in the liver is a spectrum, and you go from a healthy liver, which is F0 to F1, meaning fibrosis 0 or stage 1, where their patient may have no fibrosis or no scar in the liver. And then as they have disease progression over time, they eventually will have increasing stage, and then they will have stage 4, which is cirrhosis. And this creates a lot of other tension with patients because they hear stage 4 disease, and that's put in the chart, and then they think they have stage 4 cancer and have 6 months to live and need a liver transplant. And so we always try to explain patients that this is all a spectrum. And once patients get cirrhosis, it's not that they immediately need a transplant, it's just that they're at higher risk of other complications such as varices, ascites, and some things we'll talk about later. So historically, the number one way we would assess for fibrosis would be the liver biopsy. And this is where we would put a small needle into the liver, take out the tissue, and look at it under the microscope. It still is considered the gold standard. However, it has limitations because it is an invasive procedure. There is a risk of bleeding with it. There is some discomfort that can occur. And the biopsy is a very small piece of the liver, 1/50,000th of the liver. So it's very tiny. And so sometimes that it can underrepresent what's going on. So we've looked for other non-invasive ways to assess for fibrosis. And on the right, you can see FibroTest. And there's many different proprietary models looking at different blood products, blood compounds that can help us predict how much fibrosis a patient has without the biopsy. And then we also in the middle have FibroScan, and this is a technology we have used very frequently, part of our routine assessment of patients at KU. Next slide. So for those of you who are not familiar with FibroScan, this is where we have a device with a probe that we put on the side there next to the liver. It does a gentle tap, which sends an energy impulse, and then that goes through the liver. And from that, you can extrapolate how much scar tissue there is in the liver. So it is a non-invasive way to assess for fibrosis. It takes about 2 minutes if it goes smoothly, so very quick, painless, non-invasive way, and really the standard that all liver clinics now follow as far as assessing fibrosis. And what's really nice about this as well is you have a dynamic measurement where you can follow this over time, where certainly you weren't doing biopsies every 6 months or every year on patients. And so this is a way that we can follow them over time and see how they're doing. So if you hit the next 2 buttons, please, to advance. What you will get is after you do the examination, you will generate what's called the liver stiffness score, and that's that orange number in the red box. And then if you hit the next slide, please. This will correlate then with how much scar tissue there is in the liver. And for the different diseases, there are different cutoffs on what that liver stiffness score correlates with the amount of fibrosis. And this shows a color gradient that we show patients and help them understand where in the spectrum how much scar tissue they have. So if they're in the green, usually their stiffness score is below 7, but if they have cirrhosis or advanced fibrosis, they're above 12 to 14. And so we can give them a very quick visual estimate of how much fibrosis and scar tissue. So in PBC and autoimmune hepatitis, these are tests that we do in our patients on an annual to every other year basis to follow them. However, the one limitation of FibroScan is it does not allow you to get the tissue, so you can't look at a cellular level on what patterns of inflammation they have or how much inflammation they have. This simply just tells us how much scar tissue they have. Next slide. So PBC has some treatments that we do have available to offer our patients. The one that everyone usually knows about is ursodeoxycholic acid, or known as ursodiol. And so many people may not know where this drug originated from. And the Chinese culture had known for a long, long time that there were healing properties from bear bile. And so dried bear bile was given to patients with liver conditions. And so from that bear bile, they've synthesized the ursodiol. And so that is where that came to be. So most people don't think about that. But if you think of the word ursus for bear, that's where the word ursodiol comes from. In fact, one of my patients was so concerned about this that they did not want to take medication because they were afraid a bear had to die for them to get their ursodiol. And certainly that's not the case now, but something to be aware of, an interesting history of medicine. So ursodiol came to prominence in the 1990s. There was a landmark paper in 1991 showing its efficacy in PBC patients. This is dosed on a weight-based dosing, so we dose it based on 13 to 15 milligrams per kilogram per day. And this has a number of different effects in the liver. It helps bile percolate and flow through the liver. As a result, it becomes cytoprotective and reduces inflammation. This can show improvement in the biochemistries, but most importantly, improvement in survival and reduced need for transplant. And this is a lifelong medication for these patients. Once they are diagnosed, they are started immediately, and then they're on the medication the rest of their life. It is important to note that a lot of these patients are on cholestyramine, as I'll mention later, for help of their pruritus, and that can interfere with absorption. Unfortunately, about 40% of patients may not respond adequately. And what we mean by that is improvement or normalization of the alkaline phosphatase. So that has been an unmet need for patients with PBC. Side effects are generally pretty well tolerated. Occasionally we'll have patients with diarrhea or thinning of the hair, which can become an important factor. Next slide. So the other FDA-approved treatment that we currently have for PBC that was approved in 2016 is obeticholic acid, and this is dosed at 5 to 10 milligrams daily. This is a farnesenoid X receptor agonist, and this is used for patients who have an inadequate response to ursodiol or they are intolerant of ursodiol. Overall, we see a 21 to 25% reduction in alkaline phosphatase with these patients. However, the number one side effect with this drug is pruritus, and as I already mentioned, this is a very common side effect. So you can imagine we're giving a treatment to help a disease that causes itching, and your drug's number one side effect is itching. That can be a very tough combination. So that does limit its use for patients. And then in 2018 and later in 2021, there was an advancement with a black box warning by the FDA because there were some poor patient outcomes in cirrhosis itself. So we do not dose this drug for patients with decompensated cirrhosis. Fibrates have also been studied and utilized more in Europe than in the United States. They have the advantage of being inexpensive, but they are not FDA approved for ursodiol, and the use is discouraged in decompensated liver disease. And then we have two other new products that are being evaluated by the FDA and hope to get some positive information from that later this year with use of elafibranor and saldalopror, and that will be forthcoming here in the future. Next slide. So what are the symptoms that we see? As I mentioned, fatigue is a major symptom for these patients. And so one of the things when we're managing that is we have to look for other problems going on. We want to exclude thyroid disease, depression, sleep apnea, anemia, things that could also contribute to fatigue. There have been a number of drugs studied, but unfortunately none of them have shown any benefit. So I recommend my patients stay well hydrated, follow a healthy diet, get good rest, kind of standard things to help with their fatigue. I mentioned pruritus is really the Achilles heel of this disease, where it can be quite disabling. So we have a number of different drugs that we go through, and each provider kind of has an algorithm that they follow. But we start with antihistamines, and then our bile acid sequestrants are really our mainstay treatments. The other drugs I've listed here have pluses or minuses, but rifampin is utilized, naltrexone, sertraline, and phenobarbital can be helpful in the right patient population. And then, as already mentioned, Zika syndrome symptoms are common, so using eye drops, mouth coat, other things to help with the dryness of the mucosal tissues is important. Next slide. So PBC can cause portal hypertension without cirrhosis, and so we do occasionally see patients will develop features of portal hypertension, specifically esophageal varices, which can bleed, and so we do baseline EGD at diagnosis to evaluate for varices. Also, to tie into women's health, we see a high predominance of bone disorders in these patients, specifically osteopenia and osteoporosis. This has to do with the malabsorption of fat-soluble vitamins, specifically vitamin D. So I might be one of the big order a lot of bone densities in the health system, because following these patients and keeping track of their bone health with cirrhosis and with PBC, that we do check that on a regular basis. And so that is something that we follow quite frequently. We also can see lipid disorders in these patients. There's an increase in lipoprotein X in these patients, and so these patients may have higher cholesterol value, LDLs than expected, and there's a concern for potential increase in cardiovascular disease. And as mentioned, we monitor fat-soluble vitamins for deficiencies because of the cholestasis and malabsorption. Next slide. So unfortunately, if patients do not respond to treatment or they have progression of disease, then ultimately we have to look at a liver transplant. The good news is that we have excellent outcomes with liver transplant for PBC. We have graft survival approaching 72% at 10 years and patient survival approaching 80% at 10 years. So for a patient who is miserable, dying from their disease, with liver transplant, they can get a complete new lease on life and have a complete change in their perspective. Unfortunately, the disease can recur, and we see a 50% recurrence rate at 20 years. Some studies have shown cyclosporin-based immunosuppression may be more beneficial to delay recurrence, and there's increasing data coming out that ursodiol may be beneficial as well. And so many of these patients are placed back on ursodiol even after liver transplant. Next slide. So there is an entity called anti-mitochondrial antibody negative PBC. So this is a small percent of the population, but you may encounter this. And these are where patients have features of PBC, but their anti-mitochondrial antibody is negative. The blood test that we check for these patients is the SP100 and GP210 antibodies. So these are something we're doing more frequently now. So you may see that come across on patients that are undergoing autoimmune liver disease workup. Next slide. So I'm going to switch gears now and then talk about autoimmune hepatitis for the remaining portion of the talk. So autoimmune hepatitis is a fascinating disease as well. What's really unique about autoimmune hepatitis is it can have a very wide spectrum of disease. Many of these patients can be asymptomatic and have no symptoms or features of the disease until they get routine blood tests as part of a work physical or a routine health maintenance assessment, and then their liver tests are elevated and starts the process of evaluation. Many of these patients can develop hepatitis and become symptomatic, and there's even an acute liver failure presentation where patients just out of the blue will show up with acute liver failure, and we need to do an emergent liver transplant on them. As mentioned before, again, a female predominance disease with up to 95% of adults and up to 76% of children that have this disease are female. About a third of these patients can have cirrhosis on presentation, meaning the disease has been going on for some time and had not come to clinical attention. So it's not uncommon for us to find advanced hepatic fibrosis when we diagnose these patients. Other thyroid diseases such as thyroid disease and celiac disease are common. Next slide. So this is a busy slide, but just to highlight the complex interactions with the immune system with the liver. At the end of the day, no one knows exactly what triggers autoimmune hepatitis for the individual patient, but we know it stems from a break in self-tolerance to hepatocyte autoantigens and can then begin this cascade of inflammatory changes within the body, centered primarily within the liver and the hepatocyte. Next slide. So how do we diagnose autoimmune hepatitis? Well, liver biopsy is critical for this disease, and patients usually have a compatible histopathology on their liver biopsy, but this is more of a transaminase disease where we'll see AST, ALT elevations. Usually alkaline phosphatase will be normal here. These patients will have an elevated IgG level. They will have the anti-nuclear antibody or smooth muscle antibody frequently positive, although 20% of patients may not have the presence of any of the standard autoantibodies. It is important to exclude other diseases such as viral hepatitis, drug-induced liver injury, or other chronic causes of liver test abnormality. Next slide. So there are two different types of classification of autoimmune hepatitis. Again, a lot of information on this slide, but the main point is that there is a type 1 autoimmune hepatitis, which is more of the classic associated with the anti-nuclear antibody and smooth muscle antibody. And then there's a type 2 that's associated with the anti-liver kidney microsomal antibody there. And as I mentioned before, this is a disease that can affect both children and adults. You can see some of the associations listed there. What I wanted to highlight is that these ANA and smooth muscle antibody can be non-specific. So just because you have a positive anti-nuclear antibody and your ALT is elevated, that does not mean you necessarily have autoimmune hepatitis. In fact, many times it can be a complex diagnosis. Next slide, please. And these are our two main scoring mechanisms that we have used for autoimmune hepatitis. And the one on the left is very busy and a small print, and that's because it shows the number of different factors that we would consider in making the diagnosis of autoimmune hepatitis. So this was the older model that was used, obviously very clinically laborious, clunky, a lot of information to take in effect. So really not very practical for a clinical perspective, but was used mostly for research trials. And then on the right, you can see the more simplified diagnostic criteria that we use. And this is important to highlight the things that we look for. So specifically, we look at the presence of autoantibodies, such as the ANA or smooth muscle antibody, the presence of IgG elevation, the liver biopsy histology, and then making sure we rule out other viral hepatitis, such as hepatitis C. So by doing that, this is a much more facile system that we can use for our patients and more clinically applicable. Next slide. So I did want to highlight the drugs and medications can induce autoimmune hepatitis. We see this not infrequently. And so I've listed some of the commonly implicated drugs that can cause a drug-induced autoimmune hepatitis. Minocycline and nitrofurantoin, are the two that we see most commonly these days, especially minocycline. It's not uncommon for a young patient to be at a dermatologist getting treatment for acne. They think minocycline's a benign drug. They're given that for a long time for their acne. And then lo and behold, they present either being jaundiced or have elevated liver tests, and they've developed autoimmune hepatitis from the minocycline. So be careful and cautious with these drugs. Monitor for liver tests if there's any concerns for changes in their clinical symptoms. And then as we've had this rapid expansion of checkpoint inhibitors, there is an entity called checkpoint inhibitor hepatitis. It looks similar histologically and clinically to autoimmune hepatitis, but it really is a different entity. The good news is that it is treated with steroids, and so we do have treatments, but we are seeing many, many more cases of this. And some of that, sometimes it's so common they don't even make it to the liver clinic, and the oncology team is already managing it, given the high incidence of this complication. Next slide. So on the liver biopsy of patients with autoimmune hepatitis, the key word you want to look for is interface hepatitis and then plasma cells. And so those are the two things that we look for. And if you have these things, those are the most common features of histological changes on the liver biopsy for autoimmune hepatitis. Next slide. So as I mentioned before, this disease can have an acute presentation with acute liver failure. And so these patients can come in very sick, come to the ICU and need a transplant within days of their arrival. We treat these patients with high-dose corticosteroids, and if they don't improve after a few days, we're going to be thinking about doing a liver transplant. In fact, liver transplant, autoimmune hepatitis is 5% of all liver transplants in the United States, so not super rare in that regard, something we do see commonly. But unfortunately, just like PBC, we can have disease recurrence here, so we do follow these patients and give them additional immunosuppression to keep their immune disease in check. Next slide. So our main treatment for autoimmune hepatitis is corticosteroids. So we utilize prednisone, usually dosed between 20 to 40 milligrams per day, followed by a slow taper. And then we have the opportunity to use budesonide as an alternative. As you may know, this is a steroid that has high first-pass metabolism within the liver. And then what we do is we transition them from prednisone to long-acting immunomodulators such as azathioprine, and then they'll remain on that drug for long-term for their treatment. For second-line agents, we use mycophenolate, and then occasionally we'll use tacrolimus or cyclosporin. And there are salvage therapies with anti-TNF and anti-CD20 treatments that have been studied. Next slide. So one of the important concepts of this disease is this is a very long-acting disease. And so this is not something that patients will be treated for 6 weeks, 8 weeks with prednisone and their liver is all better. Many times we'll see biochemical improvement and their liver tests are coming down. But if we would do a biopsy, there's still significant inflammatory activity. So current management and thinking is that you need to have patients in biochemical remission for at least 2 years with normal ALT levels, IgG levels before thinking of stopping treatment. Many of these patients will do a liver biopsy to confirm that things are quieted down, and then we will stop their therapy. But unfortunately, the majority of patients can relapse. And so when presenting this option, we see many patients just elect to stay on their treatment. This can be, however, a little difficult because we have younger women with this disorder. They're on immunomodulator therapies. They may wish to become pregnant, and we sometimes have to adjust our treatments based on desire for childbearing in the future. Next slide. And to make things even more complicated but interesting for us is that there's concepts of overlap. And so there are different autoimmune liver diseases and patients can have features of both. So I have many patients that have both features of autoimmune hepatitis and PBC. And then there's a third autoimmune liver disease called PSC, which we didn't cover today. And patients can have features of either 2 or all 3 of these diseases on their biopsy and based on their clinical presentation. And the bottom line is we treat the clinical features that we see. So if they have autoimmune hepatitis, they're treated with prednisone. If they have PBC, we treat with ursodiol. Next slide. And so we're running short here, but this is our summary slide that I wanted to point out of the 3 major autoimmune liver diseases. Sometimes it's easy to confuse these and get patients to understand the differences and providers to understand the differences. Today we covered autoimmune hepatitis and PBC. You can see some of the defining features there. Autoimmune hepatitis and PBC, as highlighted extensively, is predominantly a female disease, whereas PSC, or primary sclerosing cholangitis, is seen more commonly in men than women, and that has a completely different spectrum of evaluation and management. So you can see the key and overlapping features of the diseases here. Next slide. So then going back to our case, if you may recall, this is a 57-year-old female coming in for a physical, is found to have elevated alkaline phosphatase. The astute observer sees that this patient has xanthelasma on examination and has had isolated alkaline phosphatase elevation. So immediately this should be triggering thoughts for PBC. So the most likely etiology of this patient's findings, next slide, would be PBC. So if I was seeing a patient like this, it's appropriate to check an antimitochondrial antibody or make a referral to hepatology clinic for further evaluation. And I'd be happy in the question and answer to talk more about certain why I would think this disease over the other diseases, if anyone has any questions on that. Next slide. So there are practice guidelines out there and resources for you as a provider. If you want to learn more about these diseases, I recommend the AASLD guidelines. These are the best out there to go through the disease and talk about some of the common points that you may see clinically. Next slide. As already highlighted, these diseases can have very, very major impacts on patients' lives. So we have to work on symptom management and having a long understanding that these diseases are going to be chronic, many times leading to liver transplants. So that can create a lot of stress and worry for our patients. And so there are very good, reputable patient support organizations out there. So if you have patients with one of these diseases, I strongly support and recommend their participation with either the PBCers, which is for PBC, and the Autoimmune Hepatitis Association. And these have been great advocacy groups for patients with these uncommon diseases. Next slide. So I will be concluding there and really appreciate everyone's attention. Hopefully get us off to a good start this morning for our symposia and be happy to take questions later. So thank you very much.
Thank you very much, Dr. Taylor, for an amazing presentation and a great way to start off. Again, we don't always think of liver disease as a women's health condition, but it is. I would just ask for the participants, if you have any questions, if you could please just type them in the chat, where our Q&A function is off, so we could just follow the chat, and I'll be happy to answer or ask those questions of our speakers during the Q&A session. As we get the slides set up for our next presentation, I do have one question for Dr. Taylor. As you mentioned that for women with PBC, they're at increased risk of osteopenia or osteoporosis. And I think that's a great demonstration of what we see in women's health. Women are more likely than men to have multiple comorbidities or multiple health conditions that all seem to intersect and impact each other, which I think is where one of the I think beauties of this sort of conference is we can talk among specialties and hopefully try to break down some of the silos, so that for someone with PBC, then they need to be talking to somebody that deals with osteoporosis and show that how those conditions intersect. So I guess just one question for women with PBC. You mentioned supplementation with calcium and vitamin D. Do you check 25 hydroxy vitamin D levels at the time of diagnosis or before they start vitamin D supplementation, or how and where does that fit in?
Yeah, great question. So I monitor the vitamin D levels in my patients with PBC. We get a baseline level at initial visit, and then we'll check it every 6 to 12 months through the process. And so some days I do feel like I run a mini bone practice because I'm checking so many vitamin Ds, ordering so
Yeah.
many bone densities. And, it's been shocking to me how much bone disease has been identified in these patient populations. And, it's not uncommon for our patients as they get older then to get a fracture. And I always feel like that's a deficiency or we did missed an opportunity to help that patient that may have osteoporosis and wasn't attended to sooner before they had a major clinical event. So I'm very passionate about bone disease and our liver patients. I've been shocked at how much I've seen, and I definitely think that's a great concept of this, the cross collaboration between disciplines and areas. And this is an area where primary care providers can make a huge difference and help us as well with these systemic diseases that affect more than just the primary organ where the diagnosis is.
Awesome. And then do you see women that don't respond with vitamin D supplementation because of their liver disease? And if so, where do you go next so that we are trying to prevent their fractures?
Yeah, so I will be very aggressive about vitamin D supplementation and making sure they're taking calcium vitamin D. Sometimes we'll have patients on 50,000 international units of vitamin D 3 times a week, which is a really large dose, and hopefully we can make a dent in their levels. I do refer patients to endocrinology for assistance with medical therapy. A lot of times we'll actually institute therapy at the osteopenia level rather than osteoporosis level, just because we know these patients can progress.
And one question from the audience, from someone coming from a rural clinic: would you rather that they do the labs such as AMA and vitamin D labs prior to being referred to you, or wait until they're referred to see you for an appointment?
I think it always helps so that we know what we're dealing with. And, the first visit is, if we don't have those kind of antibodies or know what direction we're going, then we're going to be talking about all sorts of things like fatty liver, viral hepatitis. We really is helpful for us to have serologies and have an idea where the diagnosis is going at that first visit. So I welcome people to do it. I just highlight that checking the AMA could come back positive and kind of go down rabbit holes and create worry if the patient may not have the disease. So we see that sometimes in our rheumatologic patients.
Okay, awesome. Thank you so much, Dr. Taylor.
All right,
Appreciate it.
thank
We'll
you.
go to a more extensive Q&A after a couple more talks. Thank you.
Thank you.